Good afternoon. My name is Stefan. I'm an undergraduate finance student at the University of Calgary, presenting research on pharmacy benefit managers, or PBMs, and the impact of state-level spread pricing bans in Medicaid. This is one of the first studies to link drug-level Medicaid data to the timing of state policy changes, providing empirical evidence on how regulation shapes PBM profits, an area that's been largely theoretical until now. PBMs act as middlemen in the U.S. drug supply chain. They manage prescription drug plans on behalf of insurers, deciding which drugs are covered and how, and negotiating prices with manufacturers and pharmacies. They profit partly through a practice called spread pricing, which is charging Medicaid or a different health plan more than they actually reimburse pharmacies. Our research asks whether the state-level spread pricing bans actually reduce these PBMs' profits as intended, and whether this has an effect on Medicaid drug spending. Medicaid drug spending has surged by 72% since 2017, prompting many states to ban spread pricing for state programs. Ohio led the charge in 2018, and by 2022, over half the country had enacted similar bans. Yet, their actual impact on PBM profits remain largely unknown. This graphic demonstrates how spread pricing works. In this example, a PBM charges a health plan $60 for a drug, but pays out the pharmacy only $40, keeping $20 as profit. The goal of spread pricing bans is to eliminate the hidden portion of this margin, which includes both administrative fees and hidden spreads. Our proprietary dataset combines Medicaid spending and usage data on 50 high-volume generic drugs across all 50 states from 2018 to 2022. We pair this with the federal upper limit database, which caps the amount that Medicaid can reimburse pharmacies for each drug. PBM gross profit is then calculated as total Medicaid spending minus this capped reimbursement, following Mattingly's 2023 approach. The dataset captures nearly 900 million claims, totaling about $20 billion in Medicaid spending. Our model relates PBM profits to whether a state has a spread pricing ban, controlling for the number of manufacturers, total claims, prescription size, and unit price. Fixed effects capture differences across drug types, allowing us to isolate how policy timing drives variation in PBM profits. We also run several alternative models with varied outcome variables, such as total Medicaid spending. What's striking is that these spread pricing bans, meant to cut PBM profits, often have the opposite effect. We found no significant decline in PBM revenue from Medicaid. Instead, PBMs appeared to adapt, quietly reshaping how they earn money and even might increase their spreads post-ban. One of the most noticeable patterns we found is the manipulation of prescription sizes. PBMs also encourage smaller prescriptions through various formulary design tactics, which forces patients to refill more often, and every refill triggers another administrative fee, further boosting their profit levels. Lower-priced drugs and increased competitions also correspond with higher spreads, indicating how PBMs exploit market activity and complexity to maintain their margins. In short, policies intended to reduce hidden profits may actually entrench them, revealing just how adaptable these intermediaries have become. These alternative models further reinforce our findings. Spread pricing bans show no meaningful reduction in PBM revenue or Medicaid spending. In short, we show that spread pricing bans don't reduce PBM profits. They just repackage them. The structure changes, the money stays. Our results show that spread pricing bans alone barely dent PBM profits because these firms operate in an extremely concentrated market, where 3 PBMs control nearly 80% of prescriptions nationwide. That dominance gives them the leverage to rewrite contracts, hike admin fees, and employ other tactics when one revenue stream is threatened. To make regulation effective, policymakers need broader oversight, greater transparency, caps on administrative fees, and tighter control over how PBMs structure and profit from their contracts. Our analysis focuses only on Medicaid data, since PBM contracts in private markets remain unobservable. We also rely on federal benchmarks that may not capture actual reimbursements. Next, we plan to study spread pricing in commercial plans, broaden welfare measures like premiums and copays, and run event studies in states with legislated bans. Here are all of the papers that I have referenced in this presentation. Thank you for listening. This project was supported by the Pure Award and Alberta Innovates, whose support made this research possible.